Welcome to Airway Answers, expanding your breadth of knowledge. My name is Nicole Goldfarb, and I'm a speech-language pathologist and certified orofacial myologist, and I'm here to help you find your airway answers. We're in this together. Let's do this. And today's topic is titled Breathing Disordered Sleep. And I have the wonderful guest, Roger Price, here. And I'm going to give you a bio about him. And he's going to help me because this is fun. This is interesting. So Roger is actually living in Australia. And you can correct me if I'm wrong on any of this, Roger. But from South Africa. And the kind of fun thing is, I just always find it fascinating how we can connect, and we're in totally different parts of the world and different days and times. So it's Wednesday for me, Thursday for you. It's July for me and August for you. I just think that's so interesting, right?
It is. It's pretty cool stuff.
But
it's also terribly confusing because I do a lot of work in the US and in Europe simultaneously. And to juggle the time zones does my head in. I mean, forever getting it out. And then you get the change in daylight saving in the southern hemisphere and the northern hemisphere. So suddenly everything blows out by 2 hours because it's an extra hour this way and 1 hour less. It drives me nuts.
It's confusing. And now the great thing with scheduling like virtual, podcasts and interviews is it automatically adjusts the time for you. So we both won't mess up on like what day and time it is. But I thought it's kind of funny. We're even in different months. So how is August going for you so far? Is August okay?
So far it's been fine.
All right. I'll be there tomorrow. Okay, Roger.
We'll see how the day progresses.
Because you're just up early morning for you. Okay, so let's talk about you. So Roger is a respiratory physiologist and also has a background in pharmacology, but you're going to explain that a little more after I talk a little bit more about you. But I wanted you to know that I listened to you years and years and years ago when you did an interview with Dr. Stephen Park, who was one of my favorite podcasters, who I feel like he started a lot of the Airway podcasting a long time ago. So I was in beautiful Ashland, Oregon, visiting my in-laws, going for a walk out in nature by myself, and I listened to your podcast interview with him. And your voice is just so beautiful and calming and amazing. And you were talking about all about breathing, and it's not sleep disordered breathing, but breathing disordered sleep. And I just always remember that. And that was many years ago. So I think this is a great time for me to talk to you a little bit more about different thoughts that you might have. But you are recognized as the man who connected dentistry, sleep, and breathing. And I do a lot of presentations, and you probably don't know this, but I actually quote something you said from 2019 in one of my presentations. And also, I'm working on a team called the Children's Airway Screener Task Force, developing the universal screening tool in the United States that dentists will use to screen all children ages 2 to 13 for sleep disordered breathing or breathing disordered sleep, airway issues, at a young age due to the American Dental Association October 2017 guideline that all dentists should be screening these things. So during that, we have a lot of meetings we've met over the last 3 years. I let everybody on the team know this quote from you. So this is what you had said. Dentists do not enjoy their rightful place in the health system because of the notion that their expertise lies in fixing teeth. This has to be addressed because they represent an untapped source of early identification of dysfunctions, which have the potential to develop into chronic illnesses later in life. The dentist and the dental team are the perfect combination to evaluate people as they see indicators before they turn into symptoms. Much easier to treat and eliminate early. It is a simple and low-cost process with incalculable benefits down the line. And I appreciate you saying that. And Rogers Price's career began in the mid-1950s in South Africa, where he started his studies as a pharmacist at Rhodes University. As a qualified pharmacist with an honors degree in physiology and pharmacology, he then went on to qualify as a clinical nutritionist and remedial massage therapist. He studied further in the behavioral and psychological aspects of ill health and soon moved away from mainstream medicine as he realized that it had nothing to do with health at all. More than 20 years ago, Roger Price started to challenge the way that sleep disorders were being addressed and introduced the concept of airway management to the world of dentistry. The name Roger Price is synonymous with breathing disordered sleep. The prime reason that people are continuously tired, lack concentration, develop all kinds of chronic conditions, and simply do not get better. After a 7 year sabbatical in the United States, Europe, Canada, Ukraine, Russia, and having commenced at the age of 79 a master's in applied breathing sciences, Roger returned to Sydney, where he now consults for several airway based practices. And you're going to talk about a new project that you started too. So we're going to discuss that. But did you want to tell me anything else about your degrees or background?
Well, Nicole, in the early days, we didn't have the technology we have today. So we had to multitask, we had to innovate, we actually had to use our eyes and our ears and our hands and our sense of touch and our sense of feel, because disease is an intensely personal thing. It's not a scientific thing, it's not a laboratory thing, it's not a research topic thing. Disease is, why has a person created particular conditions which have become inimical to themselves? Why are they doing these things that are harming themselves? Well, they're not. They're doing things to save themselves. So what is valid for a quick, acute intervention when you're not able to breathe and you arch your back or you open your mouth or you breathe from your upper chest, because that is what you need to do at that very moment if you want to survive. Mm-hmm. That is okay at that moment. But when you're repeating that 25,000 times a day, it is no longer okay. So what we have to understand here so very clearly, if either one of us at this point in time failed to take the next breath, that will be the end of the podcast. So whether we're conscious of it or not, we are always, every living second of our lives, our bodies are focused on taking the next breath. And everything that we do is specifically to facilitate that breath. Otherwise, we die. So when you look at that, it makes sense to look at what the person does rather than what they have. Well, if you have a look at the World Health Organization statistics, 74% of deaths in the OECD countries come from non-communicable diseases, NCDs. Well, if you don't catch something, where do you get it from? You create it yourself. Not because you're stupid, but because you survive. And this starts not at the first breath. This starts in utero. This starts preconception. This starts with this domino-based cascade of environmental challenges that we have today. So if people stop for 1 second and just realize that when I was born in 1940, the world had 1.6 billion people. In my lifetime, it has increased 5-fold. Everything has quintupled. The challenges, the problems, the globalization, the movement of ethnic groups, the miscegenation, the things that are happening now that didn't happen when I studied and when I qualified and when I graduated. So we've become more and more technical. We've also become more and more litigious. We're now, everybody faces this threat about, am I within the scope of my license and is somebody going to have a go at me? And what's even worse is that when you're a male in practice today, every single female that you see at the back of your head represents, is this a possible sexual harassment case? I know it's a horrible thing to say, but it's become a business for some people.
Yes. I've heard of
And
it.
I experienced this firsthand when I was in the US. And that's another story for another time. But when somebody says to you, are you insured? Be very careful, because they're asking you that for a reason. The one could be, am I going to get some kind of rebate or some kind of reimbursement? Or can I have a go at you because you're covered?
Mm,
Now,
yeah.
isn't that sad to have to think about that?
Yeah.
All right. So much for that philosophizing on that front. Let me take you back to that 2019 comment about the importance of understanding and intervening early. I've just come back from a month in Romania. We set up 3 government kindergartens with 400 children with the Consul for Education in Romania, and we're doing a 3-year research project with them. And if anybody would like to see what we did, on our website, the International Institute of Orthopostural Education website, there's a 2-minute clip of the 5-station evaluation process that we did using exactly what I mentioned: the dentist, the orofacial myologist, the speech pathologist, the child psychologist, and the osteopath. And we have designed this research project to run over 3 years. So that's 400 children, 400 evaluations per child per year, 4,800 children evaluations that we're going to analyze vertically as well as longitudinally.
So is it kindergarten, first and second grade? Those are the years? Okay.
Well, we're doing it kindergarten, there is 3 years.
Okay. So the different group of kindergartners for 3 years. Okay.
Yeah. So
Okay.
we started off last month with the group that are graduating to go to primary school. They are 6.25 years old on average, and we had a 50-50 boys and girls split over 3 different sub-economic groups. Well, what we found was terrifying. We very closely screened 65 children. Of those, pardon me, of those 65 children, 63 had multiple dysfunctions. We're talking about retained neonatal reflexes. We're talking about inability for hand-eye coordination, incorrect swallow. They couldn't chew properly. They were investigated right from the first station, which was pediatric dentist, pediatric orthodontist, who did dental, who did oral health, who did tethers, who did functionality, who did tongue position. Then they went to the OMTs, who had a look at total facial structure and mobility and the effective movement of facial muscles. Then we did an intensive posture screen where we looked at every aspect of every child, calculating forward head position, effective weight of head or neck. We did a full
physical
capnometric.
therapist, or what type of person did that evaluation or screening?
This is the beautiful thing. It's an app called Posture Screen.
Oh, okay, use that. Yes.
So we used Posture Screen on all of these children.
Okay. Okay.
We then did a full capnographic, mechanics, dynamics, and biochemistry evaluation of their breathing. And we had them literally evaluated across every possible metric. 63 out of 65 failed dismally. And they are our control group. So when the new school year starts next month, we're going to be starting with the 3-year-olds. We have a team on the ground in Romania, and they will investigate every single child, age 3, age 4, age 5, identify the canaries in the coal mine, and start intervention. We have parental consent for every single child. This whole thing took us a long time to set up.
I can't even imagine this. And let me just kind of summarize one thing of where, if I'm getting this correctly, the 6.25-year-old age range, you showed that nearly every single one of them had a dysfunction in almost every area you screened. So now the plan is to work back and try to get them early to correct these issues that are already kind of set when they're 6 years old?
Absolutely.
Okay.
When they're 3, a lot of these things are kind of subclinical, and they're not obvious unless you know what to look for.
Right.
Well, we trained the team in what to look for. And this is the charter of IIOPE, which is the charity that we formed a year ago, exactly a year ago. And the charter is to provide a platform where on-the-ground teams in countries all over the world can use the same basis for evaluation and intervention and stop those non-communicable diseases from forming.
Yeah.
So our research project means that we'll take a 3-year-old and give them 3 years of evaluation and intervention, then compare them to the 6-year-olds who are our control group.
I just got a little chill because this sounds amazing. So it's called the IIOPE, the International Institute for Orthopostural
Education.
Education.
Yes.
And this is a research-based project. Do I have this correct?
Yes.
Okay. Wow. And then so you're going to screen the 3-year-olds and then determine how many of those, have you done that screening yet on the 3-year-olds?
No, they don't start school until the new term.
Which is that coming up soon? In
1
August?
month.
Yeah, so
Yes.
this is so great to learn about this right before this is going to kick off. So what do you estimate, what percent or amount of these 3-year-olds are going to already have dysfunction? And this dysfunction is going to be kind of subclinical, right? Well, you're going to
Very much so.
Do you think?
But the sad thing, the sad thing is that so many of them are subclinical that everybody thinks is normal. So nobody bothers with it.
Right.
Commonplace has now become normal.
Right.
The same way as dysfunction is the new function.
I like
and
that.
that's a very sad situation. So we'll have even better information because while we're doing the new year 1, we're also doing the existing year 2 and year 3. So we can show the stages of intervention.
Yes.
And how much better it is if you get them at 3 than if you get them at 4 or at 5.
And what do you think the intervention is going to look like?
It's almost impossible to say. It will be functional, it will be postural, it will be behavioral, because these children, some of them, start wearing Nike and Reebok shoes at the age of 9 months. They lack the proprioception ability that comes from the feedback through the soles of the feet.
Right.
You know, when you were in the stroller and your mom was pushing you around the street, what were you doing? You were looking around you. You were orientating yourself in space. You were looking at horizon. You were taking in sights and sounds. Now there's a 9-month-old sitting in a stroller glued to an iPad looking at cartoons. They're in a completely dysfunctional world. They have no understanding of the relativity and relationship between fact and fantasy.
Yeah.
A mother's on her cell phone talking to her friend while the baby is busy absorbing this this unreality.
It's really weird you just said that because I went for a run this morning and I just stopped and I was thinking about this exact same thing. There was a mother pushing her baby in the stroller. The baby was actually looking around, too young to probably have an iPad or an iPhone, but the mom had her cell phone like on her chest, like in her shirt, talking to her friend.
Yep.
And I was just thinking like, yeah, when my kids were little babies, I remember I was pushing them and talking about everything. I'm also a speech therapist, so I'm kind of trained to do that. But talking about all the things I was seeing and talking to the child and saying like, "Look, a house, wow," things like that. And I was just wondering, what is the child thinking? Like, do they think the mom's talking to them? Like, I don't know. It's just I just had that experience this morning, so it's kind of interesting you're saying that. But yeah, it is a different
Yeah.
world, and we're kind of breeding dysfunction. Even like probably my parents didn't use swaddles with myself and my brother, and now babies get very tightly swaddled when they sleep. There's not a lot of movement going around. Gloves, they put on little gloves on the babies so their fingers aren't going in the mouth because afraid the nails might like cut their face and things like that. But that's going to have some ramifications.
Absolutely. So the reason we're doing this is we want to get away from, here is the problem, and here is a protocol that you have to follow to fix this because of compliance. Parents do not comply, they're too busy. Children do not comply, they're too busy. So we're saying, let's gamify the entire process from day one. So when the children walk in, one room has an uneven floor, almost like a climbing wall, horizontal.
Okay.
And they have to negotiate these bumps and valleys barefoot. They have to leave their shoes and socks at the door when they walk in.
Mm-hmm.
So every minute of their lives, when they sit, when they chew, when they swallow, when they brush their teeth, they will be shown how to do this functionally.
Mm-hmm.
So it becomes part of how they grow up. So they will take this back home, and the parents will see that the children already know how to do this, so they don't have to intervene and they don't have to comply. So if any of your listeners wants to see what we're doing, the IIOPE.org website has little 2-minute videos of what we've achieved. So it's IIOPE.org.
Okay.
And there's a heading there marked HFG, which is Health for Future Generations.
Okay.
And that tab will take you through the 5 stages of what we did.
Okay.
So this is very exciting. And we have people in other countries saying, we want to do this.
And so this is in their school, and are the kids pulled out of their class a certain number of times a week, or what does this look like?
No, this is how they are in their classes.
In
When
the
they have sleep, yes, when they have nap time,
Mhm.
the teachers will walk around and make sure those lips are together, those mouths are closed.
Well, this is a dream because this makes perfect sense. This is probably the only way to do it than having like siloed therapy sessions. But if you can integrate this into the child's day, so the teachers are trained that so part of this program, you've trained the teachers.
Yes.
Okay. Can you tell me a little bit more about that? So the teachers are going to be trained to help the kids like chew with their lips closed or sit with their lips closed, and what else?
Well, yes, no.
Okay.
The teachers are too busy. The teachers are trained in how to detect these things,
Okay.
not to rectify them. So we have the team on the ground of speech therapists, of orofacial myologists, etc. And they will do the rectification. We don't want to go to this terrible situation of dumbing things down to a point of having somebody who's not qualified, who doesn't have the understanding, trying to teach orofacial myology or trying to teach breathing or whatever it is. You cannot learn these things in a 3-day weekend. You can get some information, but that information is not knowledge. So we don't want the teachers to become de facto speech pathologists. We want them to be able to watch a child and to alert the fact that that child has a nascent problem. So the school then makes arrangements with the team on the ground with parental consent. So all of that is done for the account of the therapists in each area.
And then the therapists go into the classroom, or how?
They either do that or the child goes to see the therapist privately.
Okay. So if the child needs to see the therapist, like a speech therapy or myofunctional therapy session, they would be removed from class for a certain amount of time to work on some of those.
Or they would do it after school,
Okay.
or it's not up to us to micromanage what goes on.
Mm-hmm.
The goal of IIOPE, when I conceived of this idea back in 2018, the idea was to create a platform with standardized knowledge and standardized protocols, because the requirements all over the world are very different. We don't have any therapists. We don't have anybody who delivers any form of interventional therapy. We have a bunch of people who are very highly experienced at what they do. And some of them run their own training courses. Well, if there's a speech pathologist in Constantia in Romania who wants to do a course that you run, that's between them and you. IIOPE has nothing to do with this.
Mm-hmm.
We just make sure that our education council, which is headed up, by the way, by Dr. John Coyce, he is the head of our education program.
Okay.
And we will then approve that these people can teach this to people who are working under the IIOPE banner. But we don't do any teaching. We explain the protocols and we guide what has to be done by the local team. Otherwise, we'd be in a state of chaos.
Okay.
Trying to comply with everything worldwide.
Okay. So will all kids participating in this program get, like, all 3-year-olds in the program will get initially screened? And then those
Yes.
those identified with dysfunction will be either pulled from class or have after school therapy, or the therapist will go into the classroom.
Yes.
And then the role of the teacher is also noticing dysfunction and helping to correct or helping to refer for.
Primarily, the role of the teacher is to alert, because they actually watch the children function.
Alert the child or alert the
No,
specialist?
alert alert the principal of the school.
Okay.
There's a hierarchical structure there where we don't want to breach any duty of care from anybody. We don't want to become the parent intervention. We just want a situation where the teacher says, I've watched little Susie sitting there, her mouth is open all the time. Now, what are we going to do about that? Then it's up to the parent. The parent will probably ask for guidance anyway and say, who can help me? Well, the school will then refer to their therapists on the ground. We don't want the school to become a therapy place. We want it to become a functional place where children learn how not to create these dysfunctions.
So
well, obviously, we have to go back into parental education, preconception, gestational education, the first 1,000 days. So our programs are designed at mom level.
Will the school then refer, you said they're therapists on the ground, so the people who already work with the school, or the school will then refer to the IIOPE team?
No, IIOPE has nothing more to do with it.
Okay.
So let's take, for example, the suburb in which you live. If there's a kindergarten there, you can approach them and say, we have this internationally based screening process. If a child needs some speech work, I am a speech and language pathologist in this area, and you and I will work with that child individually. You're talking to the parent now or to the school. So we don't want to have IOPE therapists, but we want to make sure that everybody who is delivering therapy does it to the IOPE standard. And that standard is done together with the IIOM, with the AOMT. It's done here with ASHA. We are not creating anything different apart from the concept of orthopostural education. And saying to you, Nicole, you cannot stop at the SCMs, or you cannot stop at the omohyoid. It's attached to something else, which is attached to something else. So you have to understand the connection and the structure of the entire organism, even though you specialize in one part of it. This is what IOPE is there for. So orthopostural means very simply, the word ortho means straight, orthodox, orthopedic, orthodontic, orthotropic. Posture is how the organism positions itself in 3 dimensions of space. Which are your sensory inputs, which are your proprioception, which is all the things that the human body was designed to do, but which we don't do anymore. So orthopostural umbrella incorporates so-called myofunctional therapy, orofacial myology, speech and language pathology, posture, breathing, biochemistry, nutrition. This falls under the umbrella of let's look at the person attached to the symptoms as well as the symptoms attached to the person. You can't separate them.
Right. So it sounds like it's like a whole body screening. Like we're looking at kids through the IOPE platform, looking at young children, screening young children at the age of 3 in like kind of a united front, like looking whole body, right? And then determining, is there dysfunction? This child needs additional support, and we're probably going to find most of these kids need some help. So kind of tailoring the classroom so it's a platform that can help the children and any outside services.
But even more important than this is the dysfunction is the understanding of this dysfunction causes additional dysfunctions elsewhere in an area that is not my area of expertise. We've got to stop this silo multidisciplinary approach where everybody believes what they do is the only thing that has to be done. We have to go interdisciplinary, where we're looking at the child as a whole, not as a series of symptoms. So it's enormously challenging.
My son is getting vision therapy through an optometrist.
Syntonics.
Okay. Is that what is that? Okay.
It's called
amazing.
Syntonics,
I mean, I took him today, and it's just so fascinating how kids who maybe have issues with eye contact or behavioral issues can get certain like labels maybe or diagnoses when perhaps there's some visual motor, visual processing things that can be corrected with like vision therapy or vision treatment. And it's just so interesting to me how already I've noticed changes in my son, and he's only been doing this for a short period of time, but the eyes aren't working in sync. And there's exercises, and the optometrist was saying, obviously the earlier we start, the better. And we can correct because the brain is plastic. And he says, before the age of 11, it's really important. 11 or 12, obviously it's going to be important at an even younger age, but that can lead to so many dysfunctions. And it's just interesting to me because this isn't a service in the schools. This is like outside service. But a vision therapist is an
Yeah.
amazing addition to the team for balance, posture, social skills. I mean, it's just, I
All
felt like,
right.
wow, this is so important, under recognized, field as
All
well.
right. Well, stop right there. Why are there balance and posture and vision issues?
Hmm.
What caused those? Compensation for survival. So if you go back to the birth process with your son and you look to see were there any interventions, was there an epidural? Was there Pitocin induction? Was it a long labor? You want to have a look and see what happened to this baby with its entry onto this planet. Was it struggling from the first breath? And then when you appreciate that from 0 to 6 months, babies are breathing 60,000 breaths a day.
Hmm.
If it has to compensate on the first breath or the second breath or the third breath, that is when the dysfunctions start to form.
Whole body dysfunctions. So can you talk now? Because it's like perfect timing to talk about. A lot of us say sleep disordered breathing, and you're big on letting us know it's not sleep only, it's breathing disordered sleep. So can you talk about that?
Yes, certainly. I've been accused of being semantic. I've been accused of being a lot of things I can't repeat on air. I have more stab marks in my back than Julius Caesar. But we tend to focus on the word. It becomes our raison d'etre. It becomes what we do and how we do it. People identify with who they are, with what they do. So if the focus is on sleep being the problem, the intervention will be during sleep, believing that that is where the solution lies. So if you take the term sleep disordered breathing, technically, nobody should ever be able to sleep. Because the moment they sleep, their breathing becomes disordered. And that is not true. That is only true if the breathing is already disordered. The
Yeah,
process of sleep makes it even worse.
right. And I think a lot of practitioners recognize that, or are noticing, the postural issues, the daytime breathing issues that the patients are having. And then that dysfunction becomes more apparent and worse at night, but it's impacting them, 24/7.
Yeah, and this, Nicole, is where the problem arises, because the number of specialists, sleep specialists, physicians that I've spoken to have said, oh, their daytime breathing's fine. And I've said to them, how do you know that? Have you checked that? They look at me like I'm speaking, Rastafarian. What do you mean? Of course they're fine. Look at them. And this is a disconnect.
Hmm.
All right, we have cases, genetic cases, comorbid cases, we have cardiovascular issues, we have neurological, neuromuscular issues where people do have sleep disordered breathing, but they are in the minority. The people that we're talking about do not wake up because they can't sleep. They wake up because they can't breathe.
Hmm.
And how do we know that? Because your two gold standard interventions are not sleep devices, they are breathing devices.
Right. And you're saying you can't separate, it's breathing. It's day and night. You're breathing. I mean, it's probably going to worsen at night, right? Muscle tone and postural issues, but there's, for anybody who has sleep disordered breathing, there's going to be awake disordered breathing as well, right?
Absolutely.
ADB.
Save for those categories that I mentioned earlier,
Hmm.
because in those categories, I don't regard those as normal.
Hmm.
I'm looking here at the vast majority of people who present with symptoms and problems, and they say, I have sleep disorder breathing. No, you don't.
Yeah.
Your breathing is disordered the 2/3 of your life that you're awake, and it becomes worse during the 1/3 of your life that you're asleep. Sticking a machine on your face or something in your mouth does not address what you're doing the next morning for the next 2/3 of your life.
Mm-hmm. Mm-hmm.
And I'm having a hard time. I mean, it's been 30 years trying to get people to understand this.
Yeah,
No,
because
daytime breathing's fine. It's only at night.
no, and you think the treatment and the therapy should also involve daytime breathing treatments and therapy, right? Can you talk
No,
about that? No, okay.
sure. There is no such thing as retraining breathing.
Like posture and
Breathing's a reflex.
mhm,
You can't train a reflex. But breathing is one of the reflexes that you can override on a short-term basis. You can suppress the breathing, or you can increase the breathing, overriding the reflex.
mhm,
And this is what most people do. They breathe their bodies, but they have no idea what their bodies need.
mhm.
So you get somebody who takes a room full of 30 people and says, okay, everybody, in for 4, hold for 4, out for 4, pause for 4. Excuse me? It might work for 3 or 4 people in that room, but what about the people for whom that rhythm is wrong? Oh, no, everybody must do box breathing and ujjayi breathing and kapalabhati breathing and yeah, okay. It's commercialized. It's a good way to make money and for people to believe they're doing something. You should not breathe your body. You should get out of the way and let your body breathe you, depending on its evaluation of demand.
Okay. Tell me more.
So your demand, sitting right here, right now, having a discussion, is totally different from the demand when you went running this morning.
Mhm,
Only your body knows what you need. You don't know. You think you know.
mhm.
So the process, and I've been working on this for 30 years, is not to teach you how to retrain your breathing. It's to teach you how to get out of the way and let your body breathe itself based on its demand.
Okay, how do you get out of the way? Tell me more. Get out of the way. Okay,
Well,
let's see.
yeah, you get out of the way by focusing on moving away from the things that you believe you should do. And the way you do that is to get yourself into a quiet place where you focus on a sound and you let these thoughts bubble around your head. I cannot guide you into a breathing pattern because I don't know what your demand is. What I can do is I can guide you into a very short-term breathing rhythm, just so that you focus on a pattern. Then I take that guide away and then allow your body, based on its demand, to adjust that pattern so that it works for you. It's a guided breathing, almost a meditative type breathing,
That's what I was gonna say.
to allow your body the freedom to understand its needs.
So, is there such a program or kind of working on like relaxing, being calm, meditative state? It's the anxiety.
Well,
Let.
10 years, 10 years ago with my 2 sons, we wrote such a program, and it was called The Power of Calm.
Mhm,
And we have an app that we created, and we called the app Address Stress,
mhm.
because that's what you need to do. And we decided we would make this free. We would pay forward to future generations the bounties that we've enjoyed out of life. And we have tens of thousands of people around the world using this app on a daily basis. And all it is a very gentle sound guide for a couple of minutes just to get you into the stage, but then to remove it, because we don't want to guide you to what we think you should be doing, because there's no such thing as normal breathing. It does not exist.
So this sounds like our breathing dysfunction has a lot to do with our anxiety.
They're totally interlinked.
And if we could meditate, be able to calm, clear our minds, handle stressors better, the breathing dysfunctions could resolve.
We can actually turn it around so that it works in our favor.
Okay. What
by
about
not manipulating it?
Okay, so that would be sort of the breathing therapy concept, a more anxiety-ridden, meditative-based. What about like the structural issues, like the malocclusion, the underdeveloped jaws, congestion, things like that?
All connected.
So we need to not just treat the structural components, but also the breathing dysfunction,
Behavioral components.
the behavioral components, breathing dysfunction, but not with a set program, more with a
No.
mindfulness approach, sort of.
Absolutely.
Yeah.
So the standard treatment today is, let's investigate this patient. Let's image them. Let's CBCT them. Let's panorex them. Let's have a look and see what are we dealing with from a structural point of view. Those are the symptoms attached to the person. Now we want to go next door and we want to say why. Let's have a look at the person attached to the symptoms and see what is the driver. Is it the malocclusion that is driving the open mouth breathing, or is it the open mouth breathing that has caused the low tongue position, which has contributed towards the malocclusion? The answer is no two people are the same. So here's a fascinating little piece of information for you. If you have three systems, what is the total possible number of combinations of three? It's 3 by 2 by 1, which is 6. Add in another two systems to make it 5. Combinations, 5 by 4 by 3 by 2 by 1.
I just remember.
So adding,
wasn't there like an exclamation mark? What is that called? Like,
yes.
No, I remember that. I just got a math flashback, like factorial, whatever that's called. Okay, yeah, go on.
That's correct. That's correct. The human body has 11 systems. Reproductive, respiratory, digestive, cardiovascular, etc. How much is 11 by 10 by 9 by 8 by 7 by 6?
I don't know.
40 million.
I was gonna hey Siri that. Okay, yeah.
40 million. 39,966,19 something, whatever. As close to 40 million as makes any difference. So it is impossible to look at an individual and know how this dysfunction is going to manifest itself in a compensation, which will compensate for something else and cause another manifestation. There are 40 million possibilities. So don't even waste your time trying to guess. So breathing has to adapt to effort and to load. And that changes. That is changing right now in this discussion. My breathing pattern over the last 5 sentences has been different from the way it was when I was sitting back calmly telling you what life was like back in 1955. The body has to sense this, and the body has to adjust. It is a dynamic process. It is not a static process that you can do in half an hour twice a day. And this is the disconnect.
Okay, so if you were to recommend to therapists out there working with children and adults, so any age, with these breathing issues, malocclusion issues, postural issues, what routes would you go for treatment? What are the various ways to address?
Well, the answer is, how long is a piece of string? The IIOPE principle is to get these before they manifest themselves.
Yeah.
Not what do I do after the horse is bolted? It's how do I close the stable door so that the horse doesn't bolt? But obviously we're realists, and we know that there are 1 billion plus people who already are damaged, and they have to be helped. But there are enough people to look after them. There are not enough people looking at prevention, because prevention doesn't make any money. But prevention saves billions of dollars. Because if we can stop those NCDs from starting, we don't have to treat them. So we're not very popular in the commercial world, but we're extremely popular at government level and at insurance company level, where people see how much money can be saved, not made. The net result is the same. If you save the money, it's there as much as if you made it.
So with the IIOPE program that you're kicking off in about a month, who's paying for the services in the program?
There's the rub. We have this all funded locally. Local Rotarian groups, local parents groups, running a barbecue on a Sunday, raising funds, government support, a Department of Education support. Everybody is kicking in so that they don't have to find the money later on. That is the beauty of the whole program. But it's not an easy program to implement, because there's a lot of opposition, as you can imagine.
And a lot of people are into symptom-driven treatment and not prevention, like you just said. So it's hard for people, like the layman, to really see this and make a change. Once we see problems, it's easier to want to fix that. So how do you see the program spreading, across the world?
Well, first of all, it spreads almost organically in countries that are less wealthy than the United States or Australia. Romania parents do not have $8,000 or $10,000 to put aside for braces. So our focus here is on the less wealthy countries. And we have waiting in the wings, we have Belarus, we have Kazakhstan, we have Turkey, we have South Africa. We have these lesser financially developed countries where they welcome something that is simple and low cost. They love what we do because it makes sense. And in every one of these areas, we work with a local university. We work with a medical school, with a dental school. And I'm busy writing an orthopostural program now, which we want to have introduced at undergrad level. So that doctors and dentists, in addition to learning about the disease state and what to do about it, will also learn about the balance state and what causes that balance state to become diseased. And in fact, this was approved by Sechenov University in Moscow before COVID and before the war. We had already set a program where I would be there 3 months a year teaching undergrad doctors and dentists the principle of functional behavior.
Mm.
But obviously that never happened.
Mm-hmm.
So we just have to change our thinking and move it away from intervention to identification and rectification,
And what do we
so
do?
that we don't have to intervene.
Yeah, and that's definitely ideal, is that early identification. What do we do for all of the rest of us who are already messed up? Like, is it you know, structural treatment, treating soft tissue, and then working on the behavioral breathing aspects?
Nicole, all we can do is help people to the extent that they wish to be helped.
Mhm.
The number of times a mother used to bring me a child when I was in the US and say, fix my son. I'll send him in with a driver. I said, no, I can't do that. I can't fix your son. You have to work with your son on a regular basis so that he learns how to fix himself.
Mhm.
No, we're too busy.
Yeah.
And this was the New York problem.
Mhm.
Power couples with massive occupations, and they would send the children in with a driver. Like, fix the child, I'll send you a check.
Yeah.
Doesn't work.
It was only that easy, where you, someone else. Yeah, because
We
it's a
wouldn't have a problem.
right, and this what we're dealing with is like lifestyle change. It's a 24/7 neuromuscular, neurological repatterning, and also conscious awareness in order to change these behaviors. So it's not a 30-minute session in and out, you know. Yeah.
All right. So here's a question. When was your body designed?
When was your body like fetal development, right? I don't know.
Nobody knows.
Okay.
How old is humanity?
Hmm.
200,000 years, 100,000 years, 500 million years, 6 million years. People toss around a billion
Hmm.
like it's nothing. I have no idea when the human body was designed.
Okay, the human body.
But I can tell you one thing. It was not designed in an atmosphere saturated with Wi-Fi and hotspots and fluorescent lighting and 24/7 iPads, iPhones, etc. Our bodies were designed when you slept when the sun went down and you woke up when the sun came up, and you ate what grew, and you did not get strawberries from California in the middle of winter
Yeah.
because you could fly them out. So progressively, we think we've adapted. We haven't. We have maladapted.
And it's
We think we're living longer. We are not living longer. We are dying longer. And that is a tragedy. Oh, we gave grandfather 2 extra years. Yeah, thank you. Incontinent in a wheelchair, drooling in an old age home, you gave him 2 extra years? Thank you. That cost him his home and it cost him his savings.
yeah. It's that concept of health span, right?
Yeah.
So, again, that book Outlive by Peter Attia. Did you read that book?
No.
Oh, have you heard of it?
What
Outlive,
was it called?
Outlive by Peter Attia, Attia. I was just talking about that with Dr. Hang and Dr. Hockle. I don't like to read so much, so I download the audiobooks and listen, but I just flew back from being out of town. I saw it's on like the bestseller list. It's all in the airports and everything, but it's really good. He talks about, um, health span and how I think you would like it. So I
Oh, love
recommend
it.
this book. Um, he just talks about exactly prevention and how modern medicine is just treating symptoms, but we can treat disease before it begins. And there's signs so many years prior to any symptoms when disease is occurring. And that's what we need to do is prevent and take those steps. He talks about, I think it's like medicine 4.0, where it's really interesting.
Yeah.
And it goes along the lines of what you're saying, but it's kind of a dismal thought because, the way humans have quote unquote advanced is really causing problems for us, right? So it's not like that's going to change. So what do we do?
We go back to first principles and we try to find the problem before it becomes symptomatic. And when it's symptomatic, it becomes treated and it ends up becoming chronic. We want to stop it from starting.
Mhm. And like, with all of the modern advances, even just lighting, like you were talking about, and then we go to screens and, iPads and iPhones and, all of our modern technology, and then little babies are holding iPads and things like that. So if we can identify dysfunction early, how do we balance that with all of the modern advancements in the world? Like, is it just going to keep this continuous battle? Are we ever going to be able to overcome what we've created?
Salvation. I believe that this current Generation Z is our solution. It is the largest generation in history. Believe it or not.
Mhm.
If you look at TikTok, TikTok has 3.56 billion subscribers.
Mhm.
90% under the age of 30. 44% under the age of 20. This generation is angry. It's angry because it's been lied to.
Mhm.
And the final straw was COVID. When these people who were young adults were told things that were patently not true. Their lives were upended, their careers were upended, all by a series of untruths. So this generation is not interested in the patriarchal top-down patting on the head. No, 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 girlie, just listen to me and do what I tell you because I'm older. They are inclusive. Our website was designed by a 22-year-old.
Mhm.
And when we appointed her at the board meeting, she said to me, age 22, are you going to do what I tell you? And everybody went, what? I said, yes, I will. Because you don't buy a dog and then keep on barking. If I ask you, how do I get to your generation? And you tell me, I will listen. I won't tell you you don't know what you're doing. Why would I ask you otherwise?
Mhm.
So we're talking now to the parents-to-be, the specialists to be, the therapists to be.
I see.
These people are very family and very health focused.
Okay. They're listening.
They are the salvation. Nicole, the world works in cycles. It always has been, it always will be. And talking of books, there's a very, very interesting book written by two American historians. It's called The Fourth Turning.
Okay.
Strauss and Howe. And they explain how the world has always worked in cycles of 4 between 20 and 25 years per cycle.
Mm.
And how some people build and they build a nice, warm, comfortable society which breeds lazy people who destroy the society. The cycle has been going forever. We are in the fourth turning. It just happens to correspond with the fourth 20-year cycle of my life. And I had my 84th birthday in Romania,
Congratulations.
down in a place called Tulicia on the Black Coast, on the Black Sea. It was amazing. The whole team set up a surprise party for me. It was just wonderful. So this fourth turning that we're in is where change will take place. And the change here is in the form of Gen Z.
Mm-hmm.
So yes, there is hope.
Mm-hmm.
And these are the people with whom we work.
Do you feel like this access to technology, TikTok, all this social media stuff is helping making health changes because people are more connected and listening? So there's positives and negatives to that.
The positive is that it gives a wonderful opportunity for people to listen and to hear.
Yeah.
But what they're listening to and hearing at the moment is not doing them any good.
Mhm.
So let's change the stream of the message. And the message is, let's look at the baby from its entry into this world, and let's be aware of what can go wrong and stop it before it becomes a problem.
Mhm.
That's the principle behind IIOPE.
Okay.
It's very challenging. I mean, it's a major thing.
It
And
sounds
I will not be around to see the outcome. There's a beautiful Greek proverb which says that a society becomes great when old men plant trees knowing they will never enjoy the shade.
I've heard that.
Yeah. And this is what I'm doing at this point in my life. What's the point of living otherwise? If you don't make a difference, you're just taking up space.
Yeah. Yeah, you've got to love what you do and help society, help people. It's connecting and helping that gives us purpose.
And you know, the interesting thing is, I'm not helping people, I'm helping me. And in helping me, if the spin-off is that it helps other people, so much the better.
Double.
What I'm doing for me so that I can feel good about me.
Right.
And people are afraid to admit that.
So all of this information is really just exciting how you're taking that big step of doing the early, it's not even early intervention so much as early identification, early prevention. And of course, everybody has dysfunction. These 3-year-olds do, so there will be intervention going on to help prevent future disease. That's what it
Yeah.
is preventing this cascade of events that build into more and more compensations. And
this is one of the reasons that IIOPE has an education board. It's just to make sure that the people who teach this stuff are teaching it correctly, that they have the correct background, that they have the correct experience. And they're not somebody who fits the yesterday I couldn't spell expert, today I are one. You know, there are too many of those around.
yeah. Well,
So no, we can't license people because we're not a licensing authority.
Mhm.
But if we can say, we've had a look at what this person teaches, and what they teach is in line with our principles, and they are an IIOPE approved provider.
Mhm.
Not certified or credited, but approved to the satisfaction of our education board. We can't do more than that.
Okay. On a person by person, therapist by therapist basis, people will.
Yes.
Yeah, that's a way to streamline and to make sure providers know what they're doing, because you and I have talked about this, that there's lots of providers who just take a course and then say they're qualified to treat, and a lot of these things take years of experience, and there's a lot of online courses, and then people say they're this profession or have this credential or certification, and they've never even worked with a patient live before. They've never done any hands-on work with patients. So it's a interesting time, and it's good that you're doing part to oversee and to help with your program, knowing that there are certain guidelines for treating and qualifying. And I appreciate all that you're doing, and it'll be really interesting if you can update us on how things go as you progress, because I'm curious how these little kids are going to be doing and progressing. And I think it's a really great thing. So this will be a really great research. And I have this website that we will check out, IIOPE.org, to watch the
Yep.
videos. I watched one of the videos that talked about in general what the program is. So thank you. Do you have
And
any?
you'll see we have some pretty interesting people on our board and on our panel of advisors.
Okay.
And we're adding all the time
Okay.
because
And is
people are now
it,
coming to us saying we're very interested.
oh, good. Well, hopefully this will spread around because this is the way, is getting to the children young and getting to the new parents or parents to be to start understanding these things. That's the only way to make the biggest change. Do you
And
have
of
any?
course, Gen Z is our market.
Yeah.
They're going to be the drivers of the future.
Mhm. Yeah.
So that is the exciting part of the whole thing.
Hmm. Yeah. We got to keep up with Gen Z and all the technological advances and social media and TikTok,
Yeah.
and got to keep up because that is ever changing. It's like once you grasp one system, then it's like a new thing comes out. So it's all about being a quick thinker. Do you have any
Yeah.
words of wisdom or any final thoughts that you want to share?
Just be happy with your day. Be happy and at peace with yourself. Put your head down at night saying, wow, can't wait for today to end so tomorrow can start.
That's sweet. That's
And that's living. That is living.
that is wonderful. Thank you so much. I really appreciate all that you do, all your information, and we'll keep track of all that progress for all those little kids. Thank you so much.
My pleasure. Lovely to be with you.
Thank you. Thank you so much for joining this episode of Airway Answers. I'm hoping some of your Airway questions were answered. Please feel free to give us a rating or a comment. And if you have any further questions, you're welcome to email me at nicole@airwayanswers.info or check out our site at www.airwayanswers.info. Thank you so much and join us for the next one.